Hello, good evening. This is Dr. Radialis from the Georgia office. I know I've been kind of missing in action for a week or so, but I was out of the country for a little while, just kind of recharging, going back to helping you guys get to where you need to be. So like every Tuesday night, I would like to start with something challenging that happened in the last few weeks and that could help somebody in their fertility journey. What I'm going to talk about is, just thought about it and I forgot, are the, what was it I was going to talk about? Anyway, hi everybody that's joining me. I'm having a moment right now, but I had picked a subject earlier concerning, it was a case that I saw. It was adenomyosis together with endometriosis and Pcos all at the same time. So I'll go ahead and start with that. And the challenge sometimes in healthcare in general is that you can have more than one issue and creating a compounding effect, okay? So don't feel bad that you're going through this journey because most of the times it's many layers that we need to go through in order to find the solution. So the magic rabbit hole. So this one particular case, she had PCOS, mild endometriosis, and suspected adenomyosis. And in her case, she had successfully had 2 children and was unable to get pregnant again the 3rd time. And she had been trying on her own for 2 years without any success. The numbers looked okay, but remember, we're not treating numbers. Her AMH was 2.3. She is 33 years old, and husband's semen analysis seemed to be normal. So, she had seen a previous fertility doctor and was indicated to move forward with IVF. It was other than the mild endometriosis found by laparoscopy and suspected adenomyosis. There was nothing else that seemed to be causing the issue. First of all, I want to point out that we don't treat numbers, and when we see you guys, we get a number, but we don't really know what your baseline is. So I cannot assume that her AMH is normal for her. It is a normal range, but it might be a decrease of what her baseline is. That's issue number 1. Also, not because you have what seemed to be mild endometriosis by laparoscopy, it does not correlate sometimes with the systemic effect of some of the cytokines and inflammation proteins that get released and how it affects you in particular. Also, endometriosis is a close relative of the adenomyosis. So then they both predispose to have kind of not only an autoimmune reaction in the system, because endometriosis is actually a deficiency of the natural killer cells produced by the spleen, or that's one of the theories. And so there's a possibility of a subclinical autoimmune reaction there. That's issue number 1. The second issue is that it predisposes you to have chronic infections, meaning that you could have a disruption in your gut and genital flora that could be causing additional inflammation and then preventing a pregnancy. And then in her case, she had a diagnosis of PCOS, and she had been irregular. So that's another thing. PCOS is a little tricky with diagnosis. She had been irregular as a teenager, had become regular later on in life, and if we assume that her diagnosis was accurate at an earlier age, and her AMH is 2.32 at 33, then what was it, 5-6 years ago? You see what I'm saying? Like, we can't treat numbers. So on a PCOS with an AMH of 2.32, that is a true diagnosis of PCOS, that is a significant decrease in ovarian reserve. So with her, we put her on triple antibiotics, assuming that there could be a subclinical infection, suggested to do some PRP and treat her like she could have decreased ovarian reserve, even though her numbers seem to be normal, just based on her clinical history together with the labs that we got on her. Her tubes were open, so she opted to do IUI first. After we tried some immune protocols, she is going to jump on the keto diet. She was placed on a series of supplements, and then we're going to do PRP. We're going to do some priming, 1 to 3 months. You guys heard me before, and then move on into stimulation, monitored stimulation with IUI. She wants to try that first, understanding that there could be a possibility of moving on to IVF if that fails. So wanted to share that with you today. Let's see what questions you have for me. Okay. Hi, everybody. Hello from Rhode Island. Hello, hello. Can we please talk about miracles with ladies 39 plus with low AMH having a baby with her own eggs? Absolutely. I am all about the miracles. I am a fervent believer that, mind over body, and there is divine all around us, and miracles happen every day. So why can't you claim yours? First of all, those of you who have heard me, it takes 5 things to make a baby: good egg, good sperm, a good uterus, if you're doing it naturally, healthy tubes, and a healthy vessel. What's the vessel? The actual woman carrying the child. So when you present with a low AMH, you still need to make sure all those things are working, and there might be some synergy between other organs in the endocrine system, okay, because we are a whole machinery. And so that's where the vessel comes in. We have to make sure, is there any adrenal fatigue? A lot of women later on in life will develop adrenal fatigue, whether it can be measured by lab or not, but then it can present as decreased ovarian reserve and luteal phase defect. That means short cycles and not a robust progesterone reaction after ovulation. How about the thyroid? The thyroid balances out the ovaries and the adrenals, okay? So we want to make sure that that thyroid is well controlled. That's why at the fertility clinics we check it so much. We like it to be the TSH, which is one of the parameters checking out the thyroid, to be less than 2.5. Okay, we find a lot of subclinical hypothyroidism, and that is linked with fertility challenges. We also find issues with the pituitary. Pituitary higher up in the brain is part of the endocrine system, and it's the natural producer of FSH and LH, and those are the hormones that we actually give you for IVF. Okay, so if there's an issue up there, you can imagine that we're going to have problems down in that cascade and potentially cause ovarian dysfunction. So we check every aspect of the endocrine system, making sure everything is working well, because the end organs are actually uterus and ovaries. So you might present with a low AMH, but it's actually something higher in the pyramid that needs to be fixed. And if you fix the problem, then the ovaries start working a lot better. Something as simple as nutritional issues. Low vitamin D is also associated with decreased ovarian reserve. So we have to go over all those things. So that's why we recommend a keto diet for everybody. Grains are not the greatest for the endocrine system, and that has several layers. One, by pushing your sugars in your blood higher up, then you initiate the insulin cascade of events, and that causes inflammation and ovarian dysfunction. And then also there is some, potential observational data showing that it could affect thyroid and ovarian function directly by causing some autoimmunity. So the diet, basic stuff, diet, eliminate toxins. Your body was naturally designed to heal itself. So if you take out the stressors, chemical, environmental, psychological, the whole 9 yards, emotional, then that's more energy towards healing. So then you will be doing better. So again, making sure your vitamin levels are right, you're eating the right stuff, drinking the right stuff, sleeping right. And then we go into potential interventions. There's priming. What's priming? It's preparing the machinery to work, right? Warming it up. So we're talking about human growth hormone, PRP, supplements like glandular therapy that I like, vitamin D, CoQ10, inositol, which is a B vitamin that helps with sugar regulation. So very, very good for PCOS. So we add all that layer in to improve ovarian function and potentially improve outcome. And an AMH, the AMH, all of these lab values, they're not set in stone. They kind of fluctuate as your body fluctuates and changes and gets better or worse. And then we have, of course, make sure the husband's okay. And like I was mentioning earlier, making sure that there's no infection or potential chronic inflammation like endometriosis, adenomyosis, endometritis. They're all kind of linking together. Okay. I hope that I answered your question. I went all over the place. Okay. Oh, yes. So I remember the subject I had chosen for today. I wanted to talk also about tubal reversals. So that's a question I get all the time. What is the success rate of tubal reversals? The success rate of tubal reversals is 15, top 20%, okay? And why? Because even if you end up with a long enough tube, that, by the way, you need to have at least 4 centimeters of a tube after the reversal is done in order for the tube to be functional. And 4 centimeters is not really that great. The ideal scenario would be to have 7-8 centimeters to potentially recuperate some of the functionality of the tube, which is what I was going to discuss. Is like, even if the tube is open, the tube is highly specialized. Each area of the tube performs a different function. So even though it might be open, if the functionality is not fully restored, that might be an issue with actually working and puts you at higher risk of ectopic pregnancy. Okay. I understand that some people rather take that route, based on personal preference or even religious inclinations. I'd had a patient that for her, IVF was not a choice because it was against her religious beliefs, and that's very honorable. But I wanted to put it out there because sometimes I get the patients that are very, very surprised that their tubal reversal failed. And it's important before you do any intervention to understand the risks and the benefits of it. So personally, I do tubal reversals quite often, and I like to go over this with the patients so they understand and they make an educated decision. But me as a woman, I would probably invest on IVF rather than do a tubal reversal, especially at my age. All right, well, let's keep seeing what other questions do we have. Do you help women in their 40s? Absolutely. 40s are the new 30s. So that is actually the bulk of my clients. I would say the bulk of my clients are low ovarian reserve and women about 40 trying to get pregnant. Can we talk about a tubal at 20, now 31, and want a tubal reversal? Absolutely. I'm glad that you pointed out your age. That was another issue that I wanted to discuss, because the age is a very important factor in determining whether you want to do a tubal reversal or not. If you're 31 and you had a postpartum tubal reversal, okay, not the interval, not the burning, whether you had a clip, a ring, or a postpartum, meaning the next day your baby was born, or a C-section tubal reversals, tubal ligations, those are easier to reverse than the laparoscopic burning, because then the chances of having enough tissue, enough tube to work with, because the way a tubal reversal works is you have two stumps, okay? I have to take out the scar tissue, so I still have to cut. So now there's the missing portion that was removed, the two stumps. I have to cut the scar tissue to create a free, clean edge, open edge, cut the other side, then put them together, okay? And then stitch them up. So I need to have tube to work with for it to be potentially successful. And the coagulation type, the one that they burn the tube, usually the damage is pretty extensive, because then you have the area that was actually burned, but the heat gets transferred, damaging even more tube besides the burnt area. Okay, so that's issue number one. Issue number two is an age factor. If you are under 35 and you want to try tubal reversal, because I understand everybody wants to make a baby in the bedroom. It is, like I said, it's very honorable, and I'm good with that decision. You still have time, in your reproductive age, to try the tubal reversal, and if that doesn't work, move on to the next thing. If you're 35 and over, 35 to 40 it's a pretty critical age in terms of ovarian reserve. After 40, we really start seeing a rapid deterioration on the ovarian function. So, playing with a tubal reversal after 35, after 36 makes me very nervous. If any of you out there is considering that choice, if you're a good candidate, the type of tubal ligation they've done on you is okay, it's one of the ones that I described, and you'd rather start there, I would not give it more than 6 months to a year after a tubal reversal to see if you get pregnant after the surgery. Okay? Is BMI a problem? It is a problem. It's not a problem for us in sense of whether we treat you or not. At CNY, we do not care about your BMI. Higher BMI is associated with a lot of, health concerns, and the fat cells make estrogen, so there could be disruption in your endocrine system that's a little harder to control. Now, like I was saying earlier, the body was designed to heal itself. So even if you're overweight and you start moving in the right direction and you lose 5-10 pounds, that could tilt the balance in your favor, okay? And your body immediately starts trying to self-regulate. So the way I see the weight situation is more of, why don't you adopt a healthier lifestyle? Going to a keto-ish. I understand Dr. Kills is very radical, and I understand why he is. Some patients really do need to become 100% carnivores, but I do understand that that's very different from what the standard American diet is. So if you transition that way, eliminate sodas, sweets, processed foods, and grains. You can start there. I'd rather you have potatoes, sweet potatoes, that you have pasta. So if you start moving into that, your body is going to start responding. You might end up losing a little bit of weight, okay? If you don't focus on the weight, but as a side effect, you will, and then suddenly things will be a lot better for you. You're going to have better results, okay? You might even, if your tubes are good, you might even get pregnant without, medical intervention. All right. Yes, I love the miracles. So yes, we do work with the very hard cases. It's pretty amazing. Not only are we the most affordable clinic, but we also get all the patients that everybody else turns away, and that just fills my heart. So I love success stories. I love to hear them from you. So either send them to me, email me, or you can reach me through Facebook. How can I get my AMH higher, FSH, and lower naturally? Like I was saying, one, change the diet, lifestyle changes, make sure you're sleeping right, you're not, smoking, drinking, having any additional toxins that don't need to go into your body. Move towards a more keto diet. We can do priming for your ovaries with human growth hormone and PRP, platelet-rich plasma therapy. I recommend to do PRP about 3 to 4 weeks during the priming, so 2 to 3 times. That would be ideal. We can do LDN to decrease inflammation, depending on your particular case, address possible chronic infection, and put you on triple antibiotics. Glandular therapy, I use that quite a bit. Make sure you're doing CoQ10. CoQ10 is also great for the guys and to improve sperm motility. Vitamin D, crucial for men and women. And if there's any PCOS concern, you might want to consider adding inositol. I don't generally recommend herbal medicine during IVF cycles because herbal medicine might interact with some of the medications that we use, and we don't know exactly how that's going to happen. And my suspicion is that it might be detrimental to the process, especially certain herbs that help the endocrine system work normally, because there's really very little normal about IVF. We are trying to get as many eggs as possible. So, drug herb interaction, not so good. All right. 12 years ago in Puerto Rico, they removed my tubes because I had an ectopic pregnancy. But in my second transfer, okay, awesome. Okay. Yeah, don't give up. So are you pregnant now, Dariana? All right. Tons and tons of questions tonight. Are more or less likely to have an ectopic pregnancy after IVF transfer if your tubes have been tied? Not really. They go back and forth. In general, there is a slight increased chance of ectopic pregnancy from IVF transfers, not related so much to the tubes, but more that the embryo could migrate, okay? Do you know when will you retrieve and transfer in Atlanta? So we are working towards that. There's a lot of levels of things that need to occur for the Atlanta office to have full IVF service. And that includes construction, hiring, permits. But we're hoping that, sometime this year. I know that you've heard different stories, March, April, May, but we're trying to do it as fast as possible. Our goal was to have it ready for the summer. So cross your fingers, pray to God that might happen still. Is high BMI a problem for tubal reversal or IVF? A very high BMI, it's going to make either procedure a lot more complicated. Not impossible, just technically harder. But like I said, in the meantime, just start working in that direction to make your body healthier and just optimize your results. It gives me anxiety that you have 36 hours to get to New York. I understand. I know it's a very, very challenging process for most of you that are traveling, and it's kind of a last minute thing. But sometimes we have to do what we got to do. All right. I had a lap and a fallopian tube recanalization, but too much scar tissue. What can I do before going straight to IVF? It is really hard to fix tubes. tubes are small, they're highly specialized. Like I was saying, I have never seen a fallopian tube recanalization that works in my life, honestly. So I would go to IVF. Okay. All right, all right. Can you all change the CPT codes to LabCorp? Yes, I think that has been checked. Did my tubal reversal last July. Will start my first cycle of letrozole and progesterone this month to see if it moves things along. How is the process? So depending on how much intervention you want, you can do a full monitoring of your cycle on letrozole to make sure that there's appropriate growth of the eggs, that we can trigger and optimize either IUI or time intercourse. Or you can do minimal intervention. I would recommend a day 21 progesterone to verify ovulation and also verify the reaction, how much progesterone you're making. Oh, I see. Oh, yes, that's right. I'm sorry you had a miscarriage. What are the percentage of having another miscarriage? It's kind of a little random. 10% of all pregnancies are lost, whether IVF or naturally conceived. So the chances that you're going to have a second miscarriage is actually small. I would recommend that you transfer only one. For those of you who have spoken with me, I always recommend transferring one. Two is not, it's not better than one, because you're putting two to compete for the space and food of one, and you do increase the chances of miscarriage. Okay, so I'm not a big advocate of putting more than one at a time, even on older ladies, for different reasons. If you're older, then you have less embryos. So you really want to give each one the best chance possible of success. No one has ever checked my other hormones or anything. I like to check on them. And I think everybody has at least that initial checkup with all of the panel. So, I mean, if you want to reach out to me on my private, send me a message through Messenger, through my Facebook. I'll take a look and see. Okay. I am. Am I Greek? All right, Maria. I am from Puerto Rico, so my first language is Spanish. I am the main doctor. I am the only doctor in Atlanta right now. We are trying, that's another challenge to get the IVF going. We need to recruit another fertility doctor for the Atlanta office, because once there's IVF, we need to have extended hours and it gets a little more complicated. I would love to guide you. I love my patients, so I would love to guide you. Just text me, send me a message through Messenger, and I'll make sure that you get on my schedule. What are my views on natural IVF? I am not very excited about it. If me as a woman goes through IVF, hit me hard with the drugs, take as much eggs as you can once. Because natural IVF means that you have no medication, you get monitored, you go through the whole process. So you spend money on monitoring, and you go through an invasive procedure, anesthesia with retrieval for potentially one egg. The IVF process, there's always a loss of eggs because you take them out of the body. So in my experience, you have a 30 to 50% loss of eggs. So you start with one, you could end up with nothing. You start with 12 eggs, and those of you that are veterans in this process, you start with 12 eggs. You never get 12 embryos. So that is kind of my view on the subject. I don't encourage it. I respect your choice once you have all the information. We are here to be your coaches, really. This is your journey, and it should be respected and honored. But that's my view on it. If you don't have PCOS, does inositol do anything for you? probably has a positive effect, but it won't be as radical as if you have PCOS. I had my tubes cut 5 centimeters 5 years ago, and what a percent to get pregnant if I had to do a reversal? Very low. 5 centimeters is a lot. The average normal tube, it's about 12, 13 centimeters. And like I was saying before, you need at least 4 after repair, but 4, that's kind of what the literature says. You really need like 7 or 8 centimeters after the repair. So that means that you need enough tube that is scarred at the end. So there's a chunk that will be lost, and there's a chunk on the other side that will be lost before they get put together. So 5 centimeters out of 12, that only leaves about 7 centimeters of tube to work with, and then you're going to lose another 2. So that puts you at 5 centimeters of a tube after reversal. So I would not put my investment on that. Sorry. Okay. Yes. Yes. Miss Bridget is sharing her story with us. She's saying, I wasted thousands of dollars on my reversal. My tube was so short. And, you know, yeah, that's what I'm saying. It's like, it gets complicated. Clips, Miss Welch, clips are a lot easier to fix because it's such a small segment that is damaged. So that, to me, it is the best reversal, the clips. Good evening. Hi, everybody. Yes, yes. I'm very spiritual, you know. I believe in a higher self, God, the universe, call it whatever you want. So yes, may the force be with all of you. All right, can we talk about ERA results and the success rates of doing them after failed transfer and chemical pregnancy loss? ERA results, what they give us. So what's an ERA? Endometrial resistivity assay. And how do you do that test? You have to do a mock transfer. So you have to do the monitoring, and you have to do all the medication that you would normally use during a transfer. And then you, after 121 hours of progesterone, to be exact, give or take, I think it's 2-3 hours, you do a biopsy, and then you are going to verify if the effect of the progesterone in the endometrium, the lining of the uterus, is appropriate for transfer. So after having biochemicals and early miscarriages, you are getting pregnant. So there's not an issue of having the right amount of progesterone in your uterus. So it's more about how to keep you pregnant. Is there something else? Are we dealing with autoimmunity? Are we dealing with chronic infection? Are we dealing with coagulation disorders, genetic issues? So I would not put my money on that. I would put my money on the rest of the workup. Okay, let's get a few more questions. Okay. I had a tubal reversal last March, and in December, SSG confirmed bilateral tubal block. Yes, IVF is the next step for you. All right. Okay. Well, time's up, ladies and gentlemen. As always, a pleasure. Tons of love from the Georgia office for all of you. We're all in this together. Everybody is here to root for you, help you through this. And if I could not get to your question, you're always welcome to reach out to me through Facebook. I'll make sure that if it's something fairly simple, I'll answer within 24 hours. If it's something that requires a little bit more in-depth discussion, then I'll make sure that one of the girls calls you and puts you on the schedule. May you have all a blessed rest of your week. I'll see you next Tuesday. Yeah, I'll see you next Tuesday at 9. The Spanish crowd, it'll be Sunday. This Sunday. I usually do it at 8. This Sunday might be a little later, but I'll need to get back on that. All right. Have a good night.